everyone. I am Swarna Kamal, working as an optometrist in ZEISS Military Hospital in UAE, and currently I am the president of United Optometrist Forum. It gives me immense pleasure to welcome all of you to the second part of our webinar series, Navigating Refractive Error and its Management. Today we delve into exciting and forward-looking topic, the second part, which is advanced technology in refractive error management. This event organized by ZEISS Vision Care, Middle East and hosted by United Optometrist Forum right here from Dubai, a global hub for innovation and collaboration. We are privileged to have 6 eminent speakers from across the globe, each a trailblazer in their field. They bring with them a wealth of knowledge, expertise, and passion of advancing eye care. Together, they will explore cutting-edge advancement, tools, and approaches that are shaping the future of refractive error management. Refractive errors are among the most common visual challenges globally, and the solution we discuss today will have a profound impact on improving vision care. From technological breakthroughs and clinical applications, we aim to provide you with insights that will empower you as a practitioner and an innovator in optometry and eye care. Thank you for joining us in this journey of learning and professional growth. Your enthusiasm and participation truly drive the success of this series. Without further ado, let us begin this enlightening session. Please join me in welcoming our first speaker of this evening, Dr. Yazan Gamo from Jordan. He will explain the protocol for management of refractive errors. Over to you, Dr. Yazan.
Thank you, Smarna. Thank you, United Optometrist Forum and ZEISS for this opportunity. Allow me to share my screen, please. Visible? Audible?
Yes.
Thank you. Thank you. So, let's start. We'll talk about protocols for management of refractive error, especially myopia. We'll basically focus on myopia management guidelines, and these guidelines have been designed based on evidence base from international standards and latest scientific research, though lately there have been some studies that are informing us about some research done under the age of 6 years in children for myopia management. So we'll keep an eye on that and update these guidelines in due time. I just would like to thank ZEISS for their assistance in helping me review all the articles needed for these guidelines. So as we are aware that by 2050, almost 50% of the global population is expected to be myopic, based on that paper by the late Brian Holden. Interestingly, though, in some parts of the world, we've reached or perhaps exceeded that percentage, which shows the accelerated growth of myopia due to the digitalization and use of digital devices, especially during COVID and post-COVID, which we, like now, we're using Zoom and online technology to contact each other. So we're not going backward at all in terms of digital devices. So we need to keep an eye on that as well, of course. So we know that there's a 7-fold increase in myopia prevalence from childhood to adulthood, from the age of 6 to the age of 15. I've just published a paper on how to screen children in schools by teachers. However, at the same time, we managed to collect cycloplegic refractive error data on 6-year-old and 15-year-old, and we found a doubling in the prevalence of myopia, reaching almost 20% of the child population by the age of 15. Can you imagine 1/4 of your country is simply myopic before even reaching adulthood? That is quite scary for us as healthcare professionals. So for that, as we said, there's an urgent need for standardizing management and early intervention. We know that higher prescriptions pose increased threats of disease. Just to highlight a little bit, for example, myopic macular degeneration, retinal detachments, cataracts, decreased visual acuity. And let's take one example, myopic macular degeneration. The complications increase by 800%. The chance if you are above the 6 diopters limit. Can you imagine what would the child suffer when they grow up having such high levels of prescriptions? How difficult it is for an eye care professional to manage that. So we need to ensure to detect, manage myopia as early as possible so that we don't reach these high levels of prescription later in their lives. And with that, we can start with mitigation. We need to introduce lifestyle changes, simply letting them play outdoors, which is very important. Ensuring, for example, that we don't have myopia at a younger age, because a younger age of myopia is an issue that will allow myopia to progress higher. And these are the cutoff refractions of cycloplegia that you need to monitor and prevent as much as possible. There are things that we cannot prevent, such as ethnicity, especially Asian ethnicity. Having both parents as myopic, being myopic, for example. However, we can increase time outdoors. If you can do it for more than 2 hours per day, that will be ideal. I also, at the same time, try to decrease the near work activities for children, less than 2 hours near work per day. Please remember that school work doesn't should not be counted in the near work. It's the using the iPads and for entertainment purposes, not for teaching and education purposes, of course. And the early screening and evaluation, which is very important. Measurements, and this is one of the protocols that I like to advocate for. We need to have cycloplegic refraction and axial length measurements whenever possible, at least yearly. And in all visits, you need to have a thorough case history, you need to conduct good accommodative tests and binocular vision tests, and we need also to assess the eye health as well. As we said, cycloplegic refraction annually. The suggestions that I wrote here are based on protocols used by pediatric ophthalmologists in my country. You can follow the current regulations or protocols in your own country or your own hospital or clinical setting. These are just only recommendations. And we need to conduct dilated fundus examination using an OCT or fundus photography, if possible, of course. You need to have a good idea about demographics. I worked in so many countries in the Middle East and North Africa, acting as a consultant or educator or trainer, and I've seen very poor, basically recording of patients' data. Uh, I used to work in the low vision clinic for so many years, and whenever the retina specialist send me a patient, I tell them I don't have any data for that patient. I need you to help me to follow up. And this is very important for both ophthalmologists and optometrists. We need to have as much data as possible for each child we examine. You need to assess the risk factors and include them in your records as much as possible. Advocate for the changes in the lifestyle as we've discussed, and as very important for you to assess parents' knowledge, awareness, and willingness to go through the myopia management or refractive error management journey. It's very good if you can have such a chart where you can plot the changes in refraction, the spherical equivalent of refraction, of course. And it's good to aim, as per the reviews of the Food and Drug Administration in the US in their review paper, to aim for less than half a diopter annually. And if every 6 months you can do a non-contact axial length measurement as an IOL master, for example, that will be perfect. If you want to fit contact lenses, a corneal topographer is absolutely necessary. And plot the axial length changes and try to aim for less than 0.2 millimeter change. And of course, start your myopia intervention using one of the corrections advocated for. We can start with ortho-K, for example. However, it requires special instrument, a thorough follow-up, and ensuring that there are no keratitis as a consequence of that. And the children are willing to wear these lenses and the parents are aware and the thorough cleanliness. So you need to take these into consideration, of course. Multifocal soft contact lenses, very few of them, if just only one of them is available as FDA approved. Most of them are not available in our region. So you might want to use an off-label multifocal. However, the range of refraction is limited and the peripheral ghosting might be an issue. So you need to consider that and inform your patients that these might be off-label use. All right? My usually go-to are peripheral defocus spectacle lenses. Us as parents, practitioners, most of the children are very aware of ophthalmic lenses and spectacles. It's not something unusual. Doesn't require specialized equipment for fitting. It's non-invasive, no side effects. These are probably one of your ideal go-to management options. Atropine is an option that can be used on its own or as a combination if the standalone management option is not working as expected. However, restricted scope of practice may have a short-term discomfort. Low dose atropine may not be available in some countries, so you need to be careful of these things. Your workflow should start with assessing the risk factors as we discussed them. And if there are high risk factors, like having plus 0.75 at age of 6, for example, having an parents that are myopic, you have an esophoria or high ACA ratio or intermittent exotropia, initiate myopia management, introduce lifestyle modification and monitor annually. If no to low risk, low risk means like you have two of the risk factors. You need to provide single vision lenses and advice on lifestyle modifications. However, a recent study, as I told you, are investigating providing peripheral defocus lenses under the age of 6. So we will monitor that and update and inform you once we have more solid evidence. And the measurements, I'm just reviewing them here for you. The accommodation test, BV tests, the eye health tests, the cyclorefraction, and the dilated fundus, and of course, the axial length measurements. And in management, it shows whatever management intervention that you as a practitioner feel comfortable with, the parents understand, and the most important thing, the child is happy with. If the child is not happy, they will not use that intervention. And we know that compliance with even single vision spectacle lenses is less than 40% among children. You don't want them to suffer more. You need to monitor the as per the management strategy, and the least cumbersome is peripheral defocus lenses after 1 month and every 6 months. Aim for less than half a diopter of annual change in refractive error, less than 0.2 millimeter axial length change annually. You may stop myopia management if the progression is stable in the past 2 years and if the age of the child is more than 18. However, there's new evidence that's coming up soon. In ARVO in April or in May, there will be more studies available and then hopefully update you with that. And these are some of the references that I used, and some of them are actually review papers that reviewed hundreds of other references. So thank you so much. And if you would like to know more about the myopia management workflow, for example, pick up your mobile phone, scan the QR code in the bottom of this page, and it will take you to a PDF file. Thank you.
Thanks, Dr. Yazan, for another wonderful presentation. Your dedication and expertise shine through, as always. I'm Ian James Pingilly, optometrist and subject matter expert for the Department of Health Abu Dhabi and member of the Advisory Council of the United Optometrists Forum. So on their behalf, I'd like to introduce Mario Lekic. He is training manager for ZEISS Vision Care East Europe, and he will present on techniques for successful prescription delivery with children.
Can you hear me?
Yes, Mario, I can hear you, yeah.
Okay, that's great. Thank you. I'm going to share my screen. Just a sec. Okay, I hope you can see my screen.
I can confirm
Yes.
that, yes.
Okay, that's great. So good afternoon, or for someone good morning to everyone. First of all, I must say that I'm not an optometrist. I'm not an ophthalmologist. I'm a mechanical engineer, but in the last 20 years, together with optical industry, I'm very proud to be here together with you. And I would like to thank you all for joining this amazing series of webinars. I must say that I would like also to extend my gratitude to Dr. Yazan for sharing this amazing protocol regarding the refractive errors. And I think that the topic that I'm about to present perfectly complement to the previous one of Dr. Yazan. As we all know, refraction is crucial of dispensing, a crucial step of dispensing spectacles. Overcorrected or undercorrected refraction in any case is not good because it can affect quality of vision. And believe me, I saw it so many times. But once when we achieve the perfect refraction, what are the next steps? Because it's not only about refraction. The refraction, as I already told you, it's very, very important. But there are two more steps to be done to reach the perfect vision. The second step is to select proper frame. And selecting the proper frame, we need to take into account the refraction. We need to take into account also the face shape or frame shape of the customer, of our patient. And of course, we need to take into account the lens solution. Once when we have all this, once when we have the perfect frame for our customers, we need to ensure that the lens solution is properly integrated, let's say like this, into the frame. Usually we call it centration of the lenses. And I'm going to mention not only myopia management centration, I would like to take this opportunity to also to mention different kind of centration for different kind of lens solution. For example, when we talk about RX lenses, it's like easy. We use boxing system. We need to make proper centration of the pupil for the far distance. And it's easy. We need to do monocular PD for the both eyes. And also, it's very important to make monocular fitting height for the both eyes. Why I'm highlighting this? Because sometimes I can see that our colleagues they are just using the total PD divided by 2 and apply to the lens. And also, sometimes our colleagues, just if they have different fitting height values, they would like to equalize them. So it's okay, and it's most of the time it's the case to have a different monocular PD, and it's okay, and it's most of the time to have different fitting height values. And this is situation, for example, for most of the RX lenses. What about finished single vision lenses? What is the rule for centration or for fitting single vision lenses? We need to lower down center of the lens. And when we talk about how much millimeters we need to lower down, people, our colleagues, they understand, yes, maybe we need to lower down around 1 millimeter, 2 millimeters. Some of them, sometimes they just told me why we need to lower down, why they're asking me, why, what is the reason to lower down? And this is something that I would like to explain here. But before that, I would like also to mention one thing, very important. Sometimes we forget to take into account bevel size. We are using boxing system, and we are measuring inner side of the box, frame box. Sometimes we forget to take into account bevel, and we know that bevel for the different frame types can be different. For example, plastic frame has a bevel around 1 millimeter, metal frame 0.5 millimeters. And imagine if you do not take into account this 1 millimeter of plastic frame bevel, then you will make an error of 1 millimeter for the fitting height. So why we need to lower down the center of the finished single vision lens? Imagine when you do the lens measurement on a visual lens, how we are doing it. We just place the lens, on the lens meter. And the chief rays goes perpendicular to the lens. What can we measure? We just simply measure the dioptry of the lens. But what happened if we change the angle of this lens? Look at it in this picture, this movie. Changing the angle of the lens, we are actually changing the dioptry of the lens. We are receiving some of the cylindrical power, we are receiving some of the axis, and consider this as a power. Imagine that our eye actually is like a digital lens meter. Placing the lens on the same way in the front of the eyes, we cannot measure the power of the lens. What we can do, we can say we can see good or not. Placing the lens perpendicular to the eye when the pantoscopic angle is 0, chief ray passing to the optical center of the lens, passing to the center of the eye rotation, and ending up to the focal point in the retina. What is the result? We don't know the dioptry of the lens, but we can say that we can see good and nice. Clear vision of field is great. But the question is, how many times we have such a situation that pantoscopic angle of the lens is 0? Most of the time, we have situation where the frame positional wear has some of the pantoscopic angles. What happened if we just simply change the angle, change the pantoscopic of this lens in this position? Look at that. Wow. So it means the chief ray now doesn't pass, which pass to the center of the lens, doesn't pass the center of eye rotation and doesn't end up to the focal point of the retina. Some other ray pass to the center of the lens, but doesn't pass to the optical center of the ray and ends up to the focal point on the retina. What is the result? Smaller clear field of view. And in this case, we need to do accommodation. Our ciliary muscles, they need to accommodate. What we need to do in this case, very simple. We need to lower down optical center of the lens to align the center of the eye rotation, center of the lens with the focal point of the retina. And it's very, very, very simple. If you have centration device, it's already implemented in so many centration devices. But if you do not have it, how can we do it? It's easy. Some of our customers very often ask me, Mario, how can I know what is the pantoscopic angle? It's easy to do. Just follow the following techniques. So first, what we need to do is to make centration for the far distance, as we usually do. Then, very simple, tell your customer to move the head up, and to look to the far distance. The current centration crosses will go up. Tell the customers, look to the far distance again, and then mark the position of the pupil. After that, when the customer is in normal position, you will see the two crosses. The first one is a red one, is for progressive lenses, and the lower one, blue one, is for the single vision lenses. Why we need to do this? Because most of the single vision lenses are calculated for the pantoscopic angle of 0 degrees. The rule of eye rotation says that we need to lower down by 0.5 millimeters, the cross per 1 degree of pantoscopic angle. One more example, if you have good correction, for example, single vision spherical lens, +3, correct centration, we will have good, nice, clear field of view with a incorrect centration of 2 millimeters, we will have the smaller and not good clear field of view. So for all single vision lenses, especially for the myopia management solutions, we should take more attention for the centration, because centration can directly influence the adaptation and efficiency of the lens. And this is something that if we have, for example, the good refraction, good frame, and if we do not do good centration, then nothing is worth it. So that would be all for my side for now. If you have any question, you can refer with the questions. Thanks a lot.
Thank you very much, Mr. Lekik, for your most practical advice on prescribing for children. I would now like to take the opportunity to introduce Ms. Heba Ibrahim, a certified optometrist and graduate of the University of Applied Scientists in Utrecht in the Netherlands, with her valuable experience assisting ophthalmology in retinal and glaucoma examinations and her current role of clinic manager at the North American LASIK and Eye Surgery Center in Dubai. She is excellently placed to share with us the role of optometrists in refractive surgery. Welcome, Heba.
Okay, I shared my screen. Is it showing?
Yes.
Okay, so I'm Heba Ibrahim. I graduated from the University of Utrecht from the Netherlands. I studied optometry, and in 2018 I came to Dubai and I started working as an optometrist. Later on I became clinic manager, and I'm working at the North American LASIK and Eye Surgery Center in Dubai. I'm going to talk today about the optometrist role in refractive surgery, preoperative and postoperative. So the content of my presentation is first the patient assessment, the preoperative testing, patient segmentation, and postoperative care. So the patient assessment. Age recommendations. The FDI approves laser vision correction for patients above 18 years old. For optimal results, the prescription should be stable for at least 1 to 2 years. That's why we recommend to do it by early 20s, because usually by then the prescription is stable. And for patients with aged above 40 plus and they have reading problems, you can recommend for the presbyond. Eye pathologies. So eye pathologies can cause complications or has impact on the outcome, such as patients with cataract, glaucoma, corneal diseases, retina diseases, severe dry eye, or any active eye infection that could interfere with the procedure or healing process. That's why you need to make sure that none of your patients has one of those eye pathologies. Systemic diseases. Autoimmune diseases increases the risk of an excessive inflammatory reaction in the eye tissue, such as, by example, reuma, arthritis. It can, you have more chance those patients to develop episcleritis or scleritis. Patients with systemic lupus, they have more chance to develop Sjögren or retinitis. Patients with arthritis, they can develop Sjögren syndrome. Patients with Graves' disease, they have severe dry eye. Patients with bowel disease, they can develop uveitis or optic neuritis. Uncontrolled diabetes, those patients, they can have chance for vitreoretinal complications, unstable refraction, or diabetic keratopathy. If the HbA1c is lower than 7.5 for those diabetes patients and no ocular or systemic complication, then you are safe to go for laser vision correction. So there are also some drugs that can affect the post-operative results of laser vision correction. By example, steroids. If you are using it chronically in high doses for at least 30 days, it can delay the wound healing. Or oral retinoids like Accutane, what is used for acne. It can give severe dry eye. Those patients, they need to stop at least for 6 months before undergoing laser vision correction. Then triptans, those can cause epithelial defects or dry eye. Mental factors. So there are patients, they have unrealistic expectations, or patients, they are emotional, not stable. Those are absolute contraindications for laser vision correction. Pregnancy and breastfeeding. So the pregnancy hormonal changes influence the eye of the patient, such as it can increase the corneal pachymetry during the pregnancy, weakening of corneal biomechanics, excessive water accumulation in the cornea and lens leading to temporal myopic shifting, increase in keratometry values, decreased corneal sensitivity and tear film production. And also it was showing that the changes in the keratometry seems to be persistent throughout the lactation period. That's why it's recommended to wait for at least 3 to 6 months after pregnancy or breastfeeding. Then contact lens use. Of course, most of the patients who will undergo for laser vision correction, they are using contact lenses. It's important to ask the patient what kind of contact lens they are using. By example, for the soft contact lens, they should stop using it 2 weeks prior. For the RGP, stop using it 4 weeks prior. And for the Ortho-K, stop using at least 4 weeks prior. And sometimes longer, because it needs some time for the epithelium to go back to the normal shape. The preoperative testing. So after the assessment, you will have the visual acuity testing. You will check the vision without the glasses, check the vision with the glasses, and check the vision in each eye individually. The refraction. So with the refraction, you will ask the patient if they are happy with their current glasses. Usually when the patient is happy with the current glasses, they expect that they will have the same prescription as well going for the laser vision correction. So whenever you do the refraction and you see that you can make the vision better with a different refraction that they have already in their glasses, explain it to the patient, show it to the patient. Because whenever they ask for the refraction and they see there's a difference, they get nervous because they are used to their glasses for many years. And suddenly you will change the refraction. So it's good to show it to them, like this is with the glasses, your vision, and this is going to be your laser vision correction vision after the procedure. What is the power of the contact lenses? So some of the patients, they come in with their glasses, and their glasses are like 15 years old, 10 years old, because they are using contact lenses. Ask the patient what kind of power they are using in their contact lenses. So when you do the refraction, you have an idea with which power they are comfortable with. Then for the autorefractor, so the autorefractor, when you do the measurement, you can see sometimes that there are fluctuations in the measurement. So whenever you see fluctuation in the measurement, you can try another autorefractor, if it's available in the clinic, to compare both measurements. Do the refraction before the dilatation of the eye. If needed, you will repeat the refraction. So whenever you do the cycloplegia refraction and you see there is a big difference between both, either you ask the patient to come back on another day, or you can repeat the manifest refraction on the day of the surgery. So the patients who are interested for laser vision correction, they are usually myopia patients, hyperopia patients, astigmatism, or presbyopia. So if they are myopic, they should be in the range between 0.5 to -10. Hyperopia range between +0.5 to +6. Astigmatism can be treated up to -5. Corneal mapping. So this is one of the most important tests that you will do for those patients. And here it's very important to explain the procedure to the patient. Tell the patient what you are testing. This will increase the patient cooperation during the test, and also the patient will feel more comfortable when they hear what are you testing? So they will feel more comfortable with going for the procedure. Make sure that the forehead is touching the headband. Don't open the eyes with the fingers. The patient should open their eyes naturally without any pressure on the eyelids. The average corneal thickness is 545 microns, and the laser removes about 16 microns for every diopter. The residual stromal thickness is minimum of 250 microns for Smile Pro, and the residual stromal thickness is minimum of 300 for the femto LASIK. So I have here a picture of the pentacam. It's very important for the optometrist to see the quality of the pictures. So here you look at the QS and it says here, okay, that means that the quality is good enough. And here I have another example, and here it's showing that the patient was blinking. So this one needs to be repeated. And here it's showing that the patient was not fixating. Dry eye evaluation. So before the laser vision correction needs to be, the dry eye needs to be evaluated. If there is any dry eye, inform the patient, let the patient be treated before going for the procedure. By example, you can test with the butt test. And if the results are less than 10 seconds, that means it is dry eye. Schirmer test, less than 10 millimeters, the same. You can evaluate the cornea to see for staining. Or you can measure the tear film with the osmolarity test if available, and it should be less than 300. Then the pupillary responses. The standard optical zone treatment is 6.5. It's important to measure the mesopic and the scotopic pupil. This should be smaller than the optical zone of the laser treatment. Typically, the scotopic pupil larger than the optical zone is contraindicated. It has been suggested that LASIK satisfaction is higher in those without large pupils. Dilatation and retinal evaluation. Inform the patient before starting the drops, how long the procedure will be, what will be the effects, and what to expect. the duration of the effects of the dilatation. Dilated pupils to get the cycloplegia, autorefraction. And then the retinal evaluation to clear the retina and the optic nerve for underlying conditions like glaucoma or retinal diseases. Patient counseling. Inform the patient how long the recovery is and when they can see clear again. If you promise them 20/20 vision the next day, they expect 20/20 vision. So if the vision is not reaching 20/20, they will think that either they are undercorrected by the next day or something went wrong with their eyes. A patient is willing to wait, even if the final results are in 3 months, but inform the patient. You have to inform the patient regarding the post-operative drops and when they can return to their activities. For example, using makeup after 1 week, swimming after 2 weeks, going to the gym the next day. The doctor will advise accordingly with the post-op follow-up as well. Patient segmentation in laser vision correction. So, of course, the doctor, they choose which procedure is the best for the patient. But when the patient comes to your room, you can give the patient already the information of the different procedures what you have available in your clinic. So you can explain to them why, for example, the Smile Pro is more expensive than the femto LASIK and what are the advantages of the Smile Pro. Show the patient videos of the procedure from ZEISS. They are available on YouTube. They are easy animation and utilize the waiting time. Sometimes the patient is waiting or the doctor is delayed. You can inform the patient regarding the procedures. So the patient, when they go to the doctor room, they are prepared. And it's also easier for the doctor to make the consultation smoothly and a little bit faster. Smile Pro. So patients who are suitable for the Smile Pro are patients with a cornea thickness minimum of 480 microns. The prescription between -1 to -10. Patient with active lifestyle sports to avoid flap dislocation because there is no flap. It's a less invasive procedure, so minimal dryness. Patients who are afraid of having a flap. And patient that wants a fast recovery. Femto LASIK. Those patients with a cornea thickness minimum 480 microns. Prescription mixed astigmatism. Hyperopia maximum +6. Myopia -0.5 to -10. And with patient that wants a fast recovery. PRK. The cornea thickness, when the cornea thickness is less than 500 microns, when there is corneal haze, corneal scar, and patient with active lifestyle sports to avoid flap dislocation. Custom treatment topo-guided with or without optical zone enlargement, irregular cornea, or patients who underwent previous laser vision correction treatment. Post-operative care. So we are seeing the patient 1 day post-op, 1 month post-op, and then 3 months post-op. We are checking the autorefractor, checking the vision, monocular, and the doctor is examining the cornea for any signs of inflammation or infection. Based on that, the doctor will modify the treatment plan if needed. Managing dry eyes. It's a common post-operative issue is dry eyes, which can be managed with appropriate recommendations, avoiding the AC, especially patients in the UAE, use of lubricating drops for at least 3 months, blink frequently, especially during computer work, or you can offer them IPL. IPL are offered in 3 sessions. The second session is done 2 weeks after the first session, and the third session is done 1 month after the second session. And that was my presentation.
Thank you, Heba, for that very insightful discussion. Our next speaker is Dr. Abdullah Nagi. He is a consultant ophthalmologist, cataract, glaucoma, and refractive surgeon, and director of the North American LASIK and Eye Surgery Center in Dubai. And he will inform us about surgical solutions for management of refractive errors.
Thank you, Ian. Let me start by sharing my presentation. Okay, so I was asked to talk about the surgical solutions for management of refractive errors. You can hear me well, right?
Yes, audible.
Yes.
no.
Okay. So as we saw in earlier presentation, myopia is on the increase. Can you imagine that half of human population is actually going to wear glasses? And of course, this is something that is not acceptable by many people. One of them is myself. I've had laser vision correction. I've lived all my life with glasses. So I know exactly what it means to wear glasses. And refractive errors are, as mentioned earlier, are either myopia, hyperopia, astigmatism, or even presbyopia. It does affect, a lot of people. These surgical solutions are always, sought after solutions because they are permanent solutions. They don't involve wearing glasses, contact lenses, and patients want to be free. I wanted to cover in my presentation the history, because nothing is best, and when you're talking about subject, is to start with how things started and what are the current techniques and what could be the possible future techniques in the refractive error. Historically, the father of laser vision correction, no, the father of refractive error correction was actually Jose Ignacio Barraquer, which was actually a Spanish doctor who was practicing in Colombia in the 40s. And Barraquer is a very well-known, center in Spain, and they have a branch here in Dubai. The idea that people can actually fix their refractive error by working on the cornea. And he advocated that we can reshape the cornea. And imagine in 1940s, thinking about reshaping the cornea as bringing a cornea and reshaping. And the way he did it was an ingenious for the time and also primitive for today, where he actually carved in or took a corneal button and then he froze it, and he used what is called cryolathe, which is something like grinding. It's grinding in the cornea in a very, and lathe is actually where you grind metal, but where he actually grounded the cornea by freezing it and removing parts either centrally or around or peripherally in a circular fashion. And he started this technique. It didn't gain wide acceptance because it was non-predictable. It resulted in different refractive errors, but the idea was there. Nonetheless, he actually also worked on microkeratome and applanation tonometry. So he was the person who started this, and everything starts with an idea. It wasn't until the 70s where Fyodorov from Russia, he actually came out with the concept of fixing myopia by flattening the center, by changing the curvature of the cornea. And the way it was done by a technology that was simple, it was accepted, which was called the radial keratotomy, where there was radial incisions made in the cornea, and the more cuts that you did in the cornea, the flatter it became. And this procedure gained a very wide acceptance right from the 80s all the way to the 90s, and maybe hundreds of thousands or millions of procedures were done, and we're seeing them now very late at their life, it was and is still an effective way of reducing refractive error. However, there are limitations to this procedure, that it had an unpredictable healing, leading either to regression or overcorrection, and it certainly causes long-term corneal instability. It causes irregular stigmatism, and it causes, structural weakness of the cornea, where they can rupture these. Certainly, we face that with cataract surgery. We're very, careful when we operate on people who have radial keratotomies. But it lasted for quite a good number of years. It was, and that's how we see the radial keratotomies. There are 90% cut through the cornea using diamond knives. It wasn't until actually the late 1980s where the laser keratomiliosis was actually introduced as a treatment modality for laser vision correction. And that was really led by the pioneer work of Theo Seiler, who is actually now considered as the father of laser vision correction. Excimer laser as a technology was actually available before that, but it wasn't until actually where they managed to have a very specific cuts and in the tissue. And this is actually a laser of a hair. And this is the point where Theo Seiler realized that we've reached the accuracy in removing tissue. So if you look into this is a cuts through a hair line. And from here, laser vision correction started. And it started all in the late 90s probably, or middle of the 90s with PRK. And in PRK, which is called surface ablation, the procedure started with removing of the epithelial layer of the cornea and then ablating a certain amount of cornea to cause flattening. Now, PRK started and gained a wide acceptance in the mid-90s all the way to the early 2000s, and it's still practiced. However, it has gained less and less popularity, mainly because of the painful recovery, slow recovery, and the haze formation when it came to a higher prescription. And it didn't have this wow effect. So laser was still something that was not a great option. Not everyone would go for it. It wasn't until the 2000 where actually the boom of laser happened, where they invented the microkeratome or the LASIK. In LASIK, and the first generations of LASIK used a mechanical blade, and also that improved over the years. And this mechanical blade, it actually created a flap. And the flap resulted in a very fast recovery, which resulted in a huge wow effect for the patient. However, things happen. As the more you do of something, the more you get to know its side effects and its potential risk. Although it had a faster recovery than it actually had other side effects. They had, it's the flap, where you could have a free flap, a torn flap, a free cap. The size of the flap was depending on the how flat or how steep of the cornea. The hinge was initially nasal, then it became a superior and back to nasal. So you couldn't control the hinge of the flap the flap structure itself was an angled flap, which resulted in more of epithelial ingrowth. And there was suction loss, there were serious complications. And we have seen all of this when I was doing a microkeratome LASIK. Now, it is a cheaper option and it's still practiced widely nowadays. And because it's, it's more economical, more affordable. And when you calculate in a very fast practice, it's also faster because it only uses one laser. You do microkeratome and then laser. So because of all these side effects of the flap, technology also improved and femtosecond laser came, and usually it gained really the wide popularities by 2010. So have you noticed that every 10 years, there is actually a new technology? So by 2010 or 2008, femtosecond was actually gaining popularity. As femtosecond technology improved as well, the speed of the lasers improved. The femtosecond laser avoids almost all of the complications of the flap that was made by microkeratome. It creates a more persistent or more consistent flap. You could control now the hinge location, which is important in management of astigmatism. You can create thinner flaps. There is less flaps, less epithelial ingrowth chances because the edges are mainly perpendicular. And you avoid all the mechanical issues that are associated with the microkeratome. As a result, more and more laser vision corrections are being done. The disadvantage, of course, is slightly slower when you do 2 lasers compared to 1 laser, and it's more expensive because you're using 2 lasers. Then ZEISS came with the newer technologies, and which is what's called the Relax Smile. And in Relax Smile, the idea is that you can flatten the cornea by removing a small lenticle or you can remove a lenticle through a small incision. That's by not ablating it, it's just by cutting it. And the way it works, that the laser creates a disc-shaped cut through the stroma of the cornea. And this disc-shaped cut is actually removed through a very small 3 millimeter to 4 millimeter incision by dissecting it away. Now, Relax Smile did gain popularity, but it was actually didn't fly very, very well from 2010 or 2012 till 2022. Why is that? Because it was, it was a slow, the results were not as good as femto-LASIK in the initial period. It gained a lot of popularity in China, in eastern part in the East, because they were not doing LASIK at the time. They're not doing any LASIK there because of some political issues there. But Relax Smile was still gaining popularity. And the advantage, of course, of Smile, that there is no flap creation in it. It is minimally invasive. It has a fast recovery. It wasn't until actually 2022 where ZEISS came up with the VisuMax 800. And in 2022, when ZEISS announced the VisuMax 800 in Amsterdam, it showed that it is an improved technology. It's a faster laser compared to the VisuMax 500. And in this case, you would see on the right side of your screen a VisuMax 800 Smile Pro finishing a smile laser in 10 seconds compared to Relax Smile and VisuMax 500, which takes around 28 seconds. So it's definitely a faster laser. And as a result, the complications possibilities with it is much less. There is a faster visual recovery and less stress on the patient and less stress on the surgeons. From that time, we actually, at the North American LASIK, signed the contract to acquire the first VisuMax 800 in the Middle East and Africa, North Africa. And from 2022, we were doing Smile Pro as our primary procedure here in the center. Not everyone is suitable for laser vision correction, however. We in any laser vision correction center, when you get consultation, there will be a group of patients who are beyond the reach of the laser. Either they have thin or irregular corneas, they have keratoconus or corneal ectasia, they have a severe dry eye or high refractive errors, and there has to be also solutions for them. And in those, we also offer implantable Collamer contact lenses, and this is an alternative to laser vision correction where a lens that is implanted into the posterior chamber behind the pupil to correct for the vision. Now, the advantages of Collamer ICL, that it doesn't affect the cornea. It can reach to numbers way beyond the laser vision correction. It doesn't cause dry eyes. It's reversible. So any surgeon who's doing laser vision correction should also be able to offer alternative treatments for those who cannot have laser vision correction. Not everyone is also suitable for ICL, because for the ICLs, you have to have a minimal anterior chamber depth. If the patient has less than 2.8 millimeter anterior chamber depth, they won't be able, or they're not licensed, there is no approval to implant an ICL in those eyes. And those patients are still stuck with not being able to have laser vision correction or not able to have ICL. And in those cases, the option is to go for a clear lens extraction and an implantable of an IOL. With this, and now even with the IOLs nowadays have improved, and they are improving with the extended depth of focus IOLs or multifocal IOLs or trifocal IOLs. So you can reach patients as well who are unable to have laser. It is an invasive procedure, and but it's a solution that is available as well for patients who are not suitable for alternative refractive error corrections. So in conclusion, the surgical management of laser vision or refractive error corrections have evolved significantly from the 1940s. Each method has its indication, advantages, limitations, and each person is its person. So you can tailor your treatment based on their need. There's no one procedure that fits all, but us as surgeons and as centers who are committed to correct refractive errors, we should be able to offer the whole range of laser vision correction to our patients. Thank you very much.
Thank you, Dr. Abdullah Naki, for your excellent presentation. I'm very happy to be here today to introduce our next speaker. I'm Carla Lanza. I am a research orthoptist. I work as a research associate at the New York University in Abu Dhabi, and I'm part of the scientific committee of the United Optometrist Forum. Our next speaker will be Dr. Mohammed Aktebi. Is going to speak about consequences of high myopia. Dr. Mohammed is an ophthalmologist, a consultant ophthalmologist at SKMC Hospital in Abu Dhabi. Dr. Mohammed, over to you.
Hello, and thank you for the introduction. I'll be sharing my Hello, can everyone hear me?
Yes, we can.
Good, then I'll start. So diseases and consequences of high myopia we'll be speaking about today. Our agenda will be covering definition of high myopia itself, demographic it's covering, and myopic sclera, myopic choroid, the effect of myopia on the retina and the optic nerve, and prevention and therapy. Thank you, first of all, for inviting me and for the very good, detailed, and elaborate speeches from the presentations from Dr. Naqi and Dr. Gammu and all the participants. So, you will hear me say many things involving thinning. Myopia has many issues with that. And the definition of high myopia, as we highlighted previously with the previous doctors and presenters, is any patient that has a refraction of less than or more than -6 dioptry in myopia, or an axial length of more than 26.5 millimeter in length. So myopia in general can be either axial or refractive, but here we're speaking about pathological, and any patient with this high myopia will definitely have, or most of the time have, an axial length of more than 25, at least 25 millimeters of axial length. So this is an A scan of a patient showing 31, 32. I have seen patients of 33, even more sometimes, of axial length. So demographic of these patients, they're more common in advanced societies with more indoor work and screen work. And by screen work, not the device itself that is the issue. Here, the work distance is the issue mainly. University students, and more common in Asians, as in Japan and China and Korea. So societies, these are very common, especially amongst university students. Myopic sclera. So we begin with the thinnings. Thinner. It's thinner, definitely, than any other patients. Sclera. So we can imagine the stretching of the eye to this length with more or less similar tissue mass. So finally, this tissue has to cover the eye, and it will just lead to it to be thinner. Could pose a problem with surgical intervention, IOL calculations, and refraction sometimes. They have or can involve a staphyloma, which is an outpouching or bulging of the sclera of certain parts of the eye, mostly and more importantly, of effect to us or touching our career or job here in trying to correct them or find the right IOL calculation when this staphyloma involves the macula, so, or the optic nerve in this case. So this is a B scan of staphyloma here. As you can see, it's an outpouching of what should have been a continuously round globe. So this outpouching is a staphyloma here, and it can pose a problem. Myopic choroid, again, it can be much thinner in myopic patients, It can be involved also in the staphyloma area, so it will go out with the outpouching, as with the retina partially. And we could have, as in the image on the right, down on the corner, intrachoroidal cavitations, cysts near the optic nerve, and myopic choroidal neovascularization, as we can see in the photo labeled C on the left, and B up there with the neovascularization of the choroid. This resembles somehow AMD in a way in its behavior and treatment, but it's because of the outstretching of the Brooks membrane and ruptures caused by the high myopia in this case, or small fractures of the Brooks inviting vessels to grow underneath and causing this neovascularization. So the myopic retina here, again, thinner. We can even see that on fundus examination. Tessellated fundus is a fundus that is a bit tigroid, or we could see the choroidal vasculature through it. It's that thin that we can see through it. So the overlaying of the choroidal pigment and vessels over a thin, transparent, almost retina will give us this appearance. So it's become like a landmark for myopia. And macular schisis, which is the separation of the layers of the retina in a specific manner, leading to changes. And most common or seen in either the periphery or the macula itself when there is a staphyloma specifically. Peripheral lattice degeneration and lacquer cracks in Brooks membrane, subretinal hemorrhages, pathological base of vitreous in the periphery or near the periphery, near the equator. In most of the highly myopic patients, we could find lots of changes around that area. So not only at the far periphery, there will be an abnormal attachment of the vitreous or tertiary and secondary, between the tertiary and secondary vitreous. There will be an extension of the tertiary meeting the secondary vitreous embryologically, but that will be the remnant of it. And this area is very fragile and prone to tears and holes and tractions, and appearance of the area in the tertiary vitreous would lead to what is called frosting in the periphery as well. So traction, tears and holes, as I explained, this is a classic findings as you do before any surgery to screen. You do well to screen for retina with the dilated fundus examination and Optus image, and retinal leading ultimately any of these complications leading to retinal detachments. So screening is key here for myopic retina. Myopic optic nerve. Here we'll have changes such as papillary atrophy, optic nerve tilting, which can pose difficulties in reading OCTs and visual field evaluation as well for myopic patients. So one would utilize maybe ganglion cell layers, but if there is schisis, again, we're in the same dilemma. So myopic patients are difficult to assess for glaucoma and nature of the optic nerve in general, or even progression of disease if they have the disease. There is what is called also dehiscences of the optic nerve or around the optic nerve, as presented here in the OCT in image B, C, and D. So these findings we can find, and they're called dehiscences on, and they're common in myopic patients. And not to forget the one and most important, myopic glaucoma. We should inform the patient also that they're prone to have that, and a gonioscopy is not a bad idea, just to confirm the angle status before surgery or before any intervention, especially in high myopic patients. So prevention and therapy in here is to promote outdoor activity, or in this case, activities that allow the patient to look further or away at a distance of maybe 10 meters or more. Um, uh, Preventing of detachment by pre-op screening, retina screening, and laser retinopexy when indicated. So I do lots of screening for my colleagues that do refractive surgery, that even changes their choice of surgery sometimes, even after pixie. So even after retinopexy, they don't like to manipulate the eye a lot, or they choose a less um, pressure implying procedure. So this changes also your planning of the surgery, and the patient should understand why we chose this procedure or the other, not only based on price, also based on evaluation, based on availability, and based on for what's best for their eye as well. So each eye, it should have, I believe, a tailor-made guideline or outline of their therapy. Prevention of progression of myopia, as Dr. Yezen explained, there is some studies that have been done on low dose atropine, but there was not, I think, studies involving the our population or gene pool as well. So we should look into that, and I'm not sure if there has been research since 2022. I was following, and then got a bit busy. I did not follow, so I'm not sure if there was any study done in the region or in Asiatic countries. And I believe the first study that based on that was somewhere in the European or Scandinavian countries, and that is a totally different population as well. So we treat the complication accordingly, and with anti-VEGF, pars plana vitrectomy if needed, if there is a detachment, cataract or glaucoma surgery if needed as well, and most importantly, educate the patient. So education, education, education. I use it in my practice. And I encourage everyone to use that, because it's the most important, that the patient understand what he's going into, what he's agreeing to, and what to expect from it. So as well, signs and symptoms of possible complications and the need for retina follow-up if they have done, for example, retinopexy prior to surgery, or we have detected atrophic holes that doesn't need or require laser or pexy in some cases, or they have a fragile retina, pathological base of vitreous with secondary and tertiary vitreous there, or frosting and traction. Patients should understand that their vision being fixed by we are fixing only their refraction. We're removing their glasses. We're not removing their pathology, which is the myopia. Myopia is bigger than that and involves many other organs in the eye, and they should keep for regular follow-up or yearly follow-up with their ophthalmologist with a dilated fundus examination or screening as well as needed. Thank you very much for having me, and it was a pleasure presenting this topic to you.
Thank you indeed, Dr. Mohammed Al-Kepti, for your sobering reminder of the consequences of high myopia. Now, please join me in welcoming Dr. Ben Hoyle to the stage. As an experienced data scientist and in his role as staff scientist, technology evangelist, and pioneer at ZEISS Vision, I know Dr. Hoyle will give us much to think about as he presents on the role of AI in optimizing your practice. Welcome, Dr. Hoyle.
Okay, thank you very much for thank you very much to the organizers and for the opportunity to present at this forum. And I would like to tell you, or I would like to discuss the potential that AI, and in particular, maybe generative AI, will have for opticians and optometrists in their practices. So very briefly, a bit about me. I've been working as an AI research scientist and a AI business consultant for the last 10 years and more. And in particular, I've been working with ZEISS for the last 7 years, trying to identify and bring new technologies, including AI and generative AI, into the company. So the outline of the talk is I will first try and provide a timeline of different AI technologies and the types or the numbers of, indeed, the numbers of use cases with which these new, which have been possible with these new types of AI technologies. Then I will concentrate on some non-generative AI solutions for supporting optometrists, and then mention also generative AI-based solutions. I will also discuss how we can keep ourselves up to date with these technologies and how we can, in fact, get started using these technologies. So this slide is supposed to show, first of all, on the x-axis we see time, so going from before 2015 all the way into the future 2025. And on the y-axis, I want just to highlight the number of potential use cases or applications that we are able to have using AI. Now, as our understanding of AI has been progressing through the years, and indeed the development of algorithms and technologies, so we've been able to give as inputs and outputs to our algorithms different data formats. So we started way back already before 2010 even with being able to provide numerical data into our algorithms, and we get numerical data out of these algorithms. And what this means is that the number of use cases which we could address or we could work on with a purely numeric approach or numeric data in, numeric data out was large but quite limited. Then from 2015 onwards, approximately, then the technology deep machine learning, and you can think of this as image-based machine learning. This then really started to become more accessible to more people and to be built into some products. So image-based machine learning means that you, instead of just having a numeric data that you give to your algorithm, now you can also give images into your algorithm. And by working with images, of course, then the problem space of so the problem space that you can tackle now with AI or with machine learning grows compared to just being able to work with numeric data. And then I hope everybody is familiar with a ChatGPT. And so this is really the first example of very useful generative AI. Generative AI itself has been around already for a few years before that. But with ChatGPT, then this algorithm allows language and indeed the intent of language to be entered into the algorithm, and of course, and language to be produced out from the algorithm. Now, this actually shows that you can have many more types of problems. So this slide shows you can now tackle many more types of problems if you can work with language rather than just working with images or rather than just working with numeric data. Now, what I want to highlight here is that the solutions that we were already developing using numerical data, they don't necessarily go away. They don't necessarily become obsolete. And we can keep building more and more solutions with numeric data as we move, and we've already been doing this, and we will continue to be doing this as we move into the future. Likewise with image-based analysis. So image-based analysis doesn't go away with the advent of generative AI. And by this, I mean deep machine learning type or standard classical image-based analysis. Still, there are more and more use cases which we can tackle with this technology. It doesn't go away, but in addition, we can now work on many more types of problems with, first of all, language and intent-based algorithms. And now in the last, say, 6 months or year, then we've actually been able to have not only language into our generative AIs, but also images and audio. And the outputs of these algorithms can also be images and audio, so language, images, and audio. Now, this enables a much larger set of problems to be tackled rather than just using images or rather than just using numeric data. And basically from now or from very short in the future, so not far in the future, we will be able to provide language and images and audio and video into our algorithms and have our algorithms produce this data as well. So of course, the number of potential use cases which you can have with this technology keeps growing. Let me first concentrate on some non-generative AI technologies. And so for this, I mean like in technologies for which you would have working with images or working with tabular data that you might find in an Excel file or that you might have in a MySQL database. Now, already with this technology, there's many problems which can be addressed. For example, we can work with recommendation engines. So you can have frame recommender algorithms, which would maybe recommend which type of frames would be a good fit for your consumers, such that that would lead them maybe to purchase a frame. Given a very large selection of frames, and you can suggest which frame would be a good fit to them. Also, the idea of personalized frames, so actually creating frames for each individual person, is also a technology that we can do, that we could implement using these classical algorithms. Likewise, lens recommendation. So what type of lens is a good fit for your consumer? And if we've already seen some talks about diagnosis and diagnosis support. Again, we have been and will continue to be using classical machine learning algorithms to support opticians and optometrists in this field as well. So, for example, with disease detection using, for example, the ZEISS fundus camera. So this you see you take an image of the retina of your patient, and you process this image using a deep machine learning algorithm, and this will actually help you to identify provide support in the identification of diseases. And also with diagnosis support is you can have online refraction tests to see how maybe your customer's vision is improving or deteriorating with time. Then we can also look at the direction of preventative technologies, again, using very standard or classical machine learning or AI algorithms. And one example here would be myopia progression curves. So imagine you can identify what demographic your patient might belong to, then you can have some idea about how their myopia might develop if it's left untreated, and even what different types of treatments, how that might affect that progression, as a way, of course, to reduce the problem or trying to help reduce the problem of myopia. Now, if we think about more maybe the in-store user journey or the at-home journey of our consumers, then using very standard machine learning or AI algorithms, then we can do things like create photorealistic avatars of our patients. And that would then allows us to put so for the consumer to be at home and to try on a pair of frames which have been digitized, and they can try these frames on in a photorealistic way at home without actually needing to be in store. And this of course can help with second pair of glasses, or you can maybe recommend which frames you think a patient might like to buy if you have new frames in stock. And of course, you can use these generative, so you can use these classical algorithms to digitize frames either that this can be done by a third-party company, or with some solutions, you could be doing this in your own stores. And then the virtual try-on we've already discussed. And of course, once you virtually try on a pair of frames, then you could be sharing this with your friends and family to get their opinion before you make a purchasing decision. So this is very much technologies which remain. There's no reason to remove these technologies, but they're using classical algorithms, deep machine learning and standard machine learning to tackle this family of problems. And now if we move over towards the types of problems which we can tackle with generative AI. And so here I use ChatGPT a lot as a proxy for generative AI, but there are many competitors to ChatGPT. And indeed, these competitors are basically catching up or have caught up with the OpenAI's version of ChatGPT. And so the differences between these algorithms maybe isn't so much of interest anymore. Before, or a year or two ago, it really was. OpenAI had the best technology and other companies didn't. But now all the companies are basically have a very good generative AI. And sort of the discussion around this is similar to the discussion around our smartphones. You know, no one really discusses what make or model smartphone you have anymore because they're all good enough. Of course, you can have ultra specialized smartphones for particular use cases, just like you can have ultra specialized generative AI algorithms for particular use cases. But on the whole, they're all pretty good for most tasks. So I've put down a set of potential applications of generative AI, and really the take-home point that I'd like you to be aware of is that there's no reason why this technology couldn't exist today, or these problems couldn't be addressed today using today's technology. The brains of the AI is already there. So we don't really need any technological advances to make any of these use cases happen, and we can go through a couple in a minute. It's really just a question of the integration of our existing processes and workflows with the brains that the generative AI algorithms provide us. And this occurs because, of course, everything's digital, by having these by what are called API calls, ways for the large language model to be taking data from some SAP systems or from some databases or from images that you provide. That's the current way that we have that we interact with generative AI. But in the very short future, we will also have generative AI running on our laptops. So we could actually have a laptop, which we could run a generative AI on that laptop, and it would act and work like a human works on that laptop. You just tell it what you want it to do, and it could, you know, open up Word, start writing a document and email that to someone, or it could provide create some training content for a new employee. That technology doesn't require an advancement in technology. It only requires an integration of our current technology for that to occur. So this is really very short term. This will be with us in the short term. Okay, so let's go through a couple of examples. You could have a customer support chatbot that can answer like an advanced type of frequency asked questions. So your customer can be at home or on their phone, and they can interact with a chatbot in a way that would help them, you know, set up an appointment with you in store, give them information about their prescription, even help them understand how to get new frame recommendations for them. You can also use a generative AI to help the digitization of handwritten prescriptions. We also have some projects doing this in ZEISS right now. And then if we move a bit away from just dealing with interactions with customers towards maybe marketing campaigns. So how do you reach more customers and bring them into the store? Well, you can use generative AI to help with the marketing content generation. You can use it to help identify what customer segment or demographic segment each customer belongs to. Then once you have that in your hand, then you can have maybe very personalized marketing or very personalized very personalized marketing to really send the message to that individual to make it more likely that they would actually come in store and then have an appointment or buy a new pair of frames. Another nice application of generative AI, again, which is completely feasible with today's technology, is to train and onboard new staff members. So imagine you have a staff member into your store, and you want to train them up with your processes. Well, you can perform this right now using today's technology, and you can help onboard. So you can train new staff. You can onboard a current staff to some new process. And of course, the onboarding of new staff and the training of current staff they would actually have a slightly different learning path, because the current staff already know a lot about the company and the new staff don't. And so you end up with a very personalized learning journey. And once you have this personalized learning journey, then you can make sure that your employees remain up to date with the latest changes you have to your processes or to compliance regulations or any other requirements. And a completely different idea of how you could be using generative AI is in the you can upload an image, for example, of the plan of your store. And you could ask GPT, is this layout is this a good layout to have a nice customer journey as the customer progresses through the store? And the answer, of course, might be, I mean, most of you are experts, and so probably you already have a good handle on this, but you could just have a fresh pair of eyes, look at this problem of store design layout, and the cost of that actually is very cheap. Cost of that is very cheap. And of course, you can use generative AI on the shop floor to educate customers, for example, about disease detection and to help with personal advertising in offers. So then how should you or how can you get started with the use of generative AI right now, and how can you stay up to date? Well, my advice to everybody is actually just to start using ChatGPT. Try to build it into your day-to-day workflow. So instead of performing a Google search, you can actually ask ChatGPT a question, and you'll get very nice results. Now, if you have experience already with generative AI, some point from the past, and you used it and you didn't think the results were very good, that's completely normal. Many people had the same experience, and however, there's been a massive evolution in this technology on a very fast time scale. So any time if you used the models more than 3 months ago and the results weren't very good, then I suggest to give the same questions or just try again, because these models are improving so much in such a short period of time that anything that you think you knew about these algorithms is completely outdated after a few months. And if you try to use generative AI right now and the results aren't very good, again, just wait a few months and then try again, because there's such a quick evolution in this technology. Before, there were issues like biases and hallucinations, but that was really a problem for 2022 and 2023. We don't really have that problem with generative AI, with the most advanced generative AIs anymore. Now, Microsoft, Google, Apple, Facebook all know or all have reacted to this new technology, generative AI. And they've reacted in a way that they see the benefit here. And so now there are, and there will be generative AI built completely into your Windows machines, into your MacBooks. Basically, will be interacting with generative AI in almost every application that we use on our laptops. And so if you're not already thinking about Gen AI, then this is going to hit you like a truck, because you're not going to be ready for these advancements which are coming really fast. And to make the most use of these advancements, we just need to prepare ourselves and start using this technology. So I've given an example here. How could you, for example, get started with using a generative AI? So here I have a screenshot from ChatGPT, and I've asked ChatGPT, how can I use generative AI to help me grow, run, and maintain my optician store? And it's given me 10 really good suggestions. You guys know your field much better than I do, so I don't want to tell you about all these details, but I would really suggest you look through them as a way of getting some inspiration about how to use these technologies. And this is a chatbot, which means if there's some component that you think is really useful, one of the ideas, then you can just ask it more follow-up questions to say, okay, I really like the idea of social media posts, for example. How would I implement this in my workflow? And you will actually have a dialogue with the with ChatGPT, and you can deep dive into this topic, and it will really provide you support on how to get started and how to, for example, build a social media following or post to social media. And I've actually, at the end of this presentation, I've shown a screenshot of all of the suggestions that ChatGPT gave to us. And this is just, and you can keep asking it for more and more questions, for more and more detailed information. So to summarize, AI has been with us for a long time already, and it's being built into a growing number of applications. Old school or classical AI algorithms do not necessarily become obsolete with this new wave generative AI, and these new and there'll be more and more applications built also with these older school technologies, because they still have a place and they're still useful. Gen AI, generative AI, is a new powerful technology that enables a much wider range of use cases and products to be and problems to be tackled. The one thing stopping all of these technology, all of these use cases for being worked on right now is simply an integration question. And 2024 really started to see many products having generative AI integrated into them. And in 2025, we will continue to see this. This technology keeps getting better, and so it really can't be ignored. That's the end of my presentation, and thanks a lot for your attention.
Hello. Thank you, Dr. Ben. That was such a informative and insightful. Thank you again. Myself, Kani, the clinical optometrist working at Sheikh Khalifa Medical Hospital. Next, I would like to invite Ms. Celine Cambrose to brief us on myocare lenses. Celine needs no introduction. She is a medical and the project manager at ZEISS Vision Center, covering Middle East, Africa, and United Arab countries. Okay, over to you, Celine.
Thank you. Good evening, everyone. First of all, I really would like to thank everyone, all speakers tonight. It was a very, very interesting webinar. We had a huge overview of myopia, of refractive errors, and this speech about centration is really important. And having an overview of what is coming up and how we can optimize AI is really interesting, because yes, it is coming fast, and we have to be ready for this wave, and we must already be working with it. So I'm just going to be very quick tonight. I just would like to give you some updates. about MyoCare and some new informations. So, can you see my screen and can you hear me, please?
Yes, we can.
Okay, perfect. So first of all, I really would like to thank Mario tonight. He only had 10 minutes talk, but I am sure that all of you really understood the importance of centration. Centration for all type of lenses. Of course, it is also very necessary to think about MyoCare centration, and it's not really complicated. But if you want to really have an effective lens to slow down myopia, having right centrations is a must. And it's very simple. So it's monocular PD, and you have to take height as an aspherical lenses. So you need to take care of the pontoscopic angle when you're taking this height. So please really
Sorry to
measure
interrupt.
the...
Celine, we
Sorry?
cannot see your. We can't see your presentation.
You can't see my presentation. Let me try again. Thank you for telling me. Okay. And now?
Yeah, now it's good.
Yes.
Carry on.
So this one is good?
Yes, yes.
Okay, so I was talking about the importance of centration. As an aspheric lens, please be careful with the monocular PD and the height. About MyoCare, so I hope that you all know now that we have the pleasure to offer to your patients some stock lenses. MyoCare stock lenses, so it's in 1.59 with a DuraVision Platinum coating, and the price is 950 dirhams. So really affordable. We also have now a big range from 1.5 to 1.59, 1.6, and 1.67, covering correction up to -10 with a cylinder up to -6. So you really can have a big range now of power and of index and of coatings for your patients. On top of that, we have the same warranty, which is a power change for free up to 9 months, non-adaptation for free, and scratches, cracks. You have a 70% discount on the first replacement, 50% discount on the second one. You can see on this page a QR code. If you want, you can tag it, and you will have a full one-pager with all latest news about MyoCare. We have invested a lot into ZEISS educational program. You had the privilege to see the presentation of Dr. Yazan. We have been working closely, very closely together to develop this myopia management guideline supported by ZEISS. You have another QR code here. If you tag it, you will have Arabic and English booklet of the myopia management guidelines. We also have a LinkedIn group. So it's a private group. You have another QR code here where you can ask to join the group. You will have all information about myopia management, about refractive errors, surgery, latest studies, upcoming events, webinar, everything. Then we have launched another program, which is the Myopia Insights Hub. It's available on our website, so www.zeiss.com/AE. You will have everything about availabilities. You will have a dedicated educational programs that I will show you after. Everything is now on our website. I was talking about a myopia education program. So you have the first essential of myopia management course, which are available on our website. It's a 5-unit program. Everything is online. You have videos, you have text. At the end of this first unit, you have an assessment. And if you have 80% of good correction, you will have a certificate of completion for this first course about essentials of myopia management. I really deeply invite you to do it because it's really a good first step, not taking too long time, and you have a certificate at the end. Now about the marketing toolbox, we still have some leaflet, some display. We have this follow-up booklet where you can write down everything about the child, about axial lens elongation measurement, refraction. You have a display with a real lens into it. If you need any of this, please reach out to me and it will be my pleasure to come and visit you. We have a new item which is really useful. We are having very good feedbacks from hospital and optical store. It's a full kids corner. It's actually a children's size desk. The idea here is really to educate the child and to educate the parents about the right behavior to slow down myopia. So you will have a quiz, you will have an explanation about what is myopia, how is myopia working. It's a children's size, so the child is able to sit directly on the desk and see how he should behave, not to be too close to the reading task, have frequent breaks, look far away as much as possible. Same, if you are interested in this type of communication tool in your optical store or in your eye clinic, please reach out to me. We had a very successful campaign with Misty Mold book. It's a children's book which are explaining what is myopia, what to do, and so on. So we did a partnership with the first book. We will have another one soon. This book is available on Amazon, so I highly recommend to have one in your practice because it's a very nice and friendly tool for children. Two new things coming up for 2025, a new display that you can see on the left. It's a display with a light inside, which is easily showing how is myopia working. So if you want any, please reach out to me. We also have a new ZEISS myopia certification. So this is, as you can see on the left, pictures of stickers that you can put in your practice, either optical store or eye clinic. We also have this little banner here, okay? To gain this, you need to do the online training, okay? So the myopia education program, which is available on our website. And you also need to do a dedicated ZEISS myopia training. If you are in an eye hospital or in your own practice as an optometrist or ophthalmologist, I will come and visit you. If you are an optometrist working in an optical store, Natalie or someone from the team will come to you. Please, if you are interested in any things, in whatever things you have seen tonight, please reach out to me. You have my email, you have my WhatsApp number, and I would be happy to come and visit you. Don't miss our next event. Next week, I'm going to Fujairah for a myopia conference. We are going to talk about myopia in the Middle East, and I want to answer to Dr. Al-Kedbi tonight. Yes, we do not have that many data and recent research about Middle East myopia evolution, but we do have some. And I will be happy to talk about it during this event. We are also really happy to welcome a new member in the team, in the ZEISS team for medical science liaison. Peter has been working for ZEISS China into research about myopia. And as he is coming, he will share his knowledge and experience in China. So this event is next week. Otherwise, we will have a big symposium, a 1-hour symposium during ESO Congress in Abu Dhabi on Saturday, February 8th. So I am done. It was really a pleasure having to organize this beautiful webinar with my colleagues from Meditech. I hope you enjoyed. I deeply thank everyone, and we are ready to answer your questions. Thank you, everyone.
Thank you so much, Celine, for the wonderful update on MyoCare lenses. Please stay back for the panel discussion. And I would also like to invite all our speakers to join the panel for the Q&A session. And a special invite to our panel moderator, Ms. Saranya Balasubramaniam. It's my honor to introduce Mrs. Saranya, whose impressive journey and accomplishments speak volumes. She is an eminent professional in the field of optometry with a wealth of extensive experience, graduate of Elite School of Optometry. She holds the distinction of being the first Indian optometrist to pass a postgraduate diploma in ophthalmology examination in the UK. Her expertise spans both academic and practical realms. Her areas of interest includes contact lenses and myopia management. She subsequently established her own Achuda Eye Care and Achuda Institute of Optometry in Ero, Tamil Nadu. And she is currently serving as Principal Academic Director and also heads a Minicon Center of Excellence at Achuda Institute of Optometry. She has been honored with numerous awards, including Dr. Abdul Kalam Women Achiever Award. Please join me in welcoming Sharanya Balasubramaniam. Over to you, Ms. Sharanya.
Ms. Kani, thank you for the introduction. It's been a brilliant session, and I must appreciate the Optoverse group for putting together such a wonderful program on myopia management. So first of all, I have a load of questions which have come in the chat box and some questions from me as well. Dr. Yazan brilliantly delivered comprehensive guideline on myopia management. So just a couple of questions for you. Do you actually start myopia management for children at risk of developing myopia? If so, what is the sort of management plan that, what is the method of management that you would advise? Would you go for spectacle lenses, atropine, or what is it that you would advise for them?
Thank you for your question. Yes, I do myopia management with children. As per protocols and guidelines, I do not do under the age of 6. So we assess the risk factors as we've discussed. As I live in Jordan, we don't have much patients with Asian ethnicity, but we do have consanguineous marriages. So we believe most of the parents will be myopic. Many of them, our children will usually be working close with their digital devices. We're lucky to have very good weather. Our springs and autumns, the weather is perfect, even during the summer. So we don't have problem with outdoor activities, but we don't have playgrounds that are made specifically for these things, as we are a developing nation. So what I usually do, consult with the parents about changing the lifestyle changes, but at the same time, I would definitely start with an ophthalmic lens because this is the easiest thing for me to actually sell as a practitioner. Both parents wear glasses. Many of the child's peers in school are wearing spectacles, so ophthalmic lenses will be the easiest thing for me, and they have been proven to be successful. So I will be comfortable with that. I will monitor and evaluate 6 months, 1 year, and if I see that the progression is not as good as what I expect, perhaps I might supplement it with atropine. However, since the scope of practice in Jordan for optometrists is limited, I would definitely need to consult with the pediatric ophthalmologist on that. And I usually work with them side by side. I don't usually work on my own. We communicate with each other. We share data of the fundus. So to ensure whatever evaluations we're doing is ensuring that the progression is not bad enough to create any structural changes. For example, I do not have an axial length measuring device in my clinic. However, when I work with the hospital, I usually utilize their IOL master. Sometimes, if that pediatric ophthalmologist is not working with that hospital, I probably will just ask them for referrals, and I factor that cost within uh, uh, the amount I tell the parents. So you need to ensure that whenever you do your calculations very, very well, because you don't want the parents feel that you're selling them extra services for the sake of money. Remember, most of our patients are very conscious about price. It might not be in some communities like the UAE, but in many other countries within our region, it's the sad story. So you need to sell it, let's say, in the most appropriate and professional way possible. I hope I answered your question.
Absolutely, thank you. I think the cost factor holds good in any part of the world, wherever we are. I think they want the best for every little bit that they're paying. So, absolutely agree with you on that. This is a general question for the whole panel as such. At least in India, we are seeing a lot of patients who are still 18 plus and progressing. The myopia is still progressing. So is this something which is a universal phenomena? And most of our myopia management protocols are aimed at patients up to the age of 18. Spectacle lenses, everything else, we keep talking about patients up to the age of 18. So how do we manage such patients? And is there anything in the pipeline coming up to manage older myopic progressive patients?
I think Celine should be the best one to answer
I
that
know.
question.
I was actually going to say, Celine, do
Am
you want to
I?
pick it up?
Am I? Am I? What we see is that as long as there is an increase in general, there is an increase of the eye, right? So I can see that for myocare, usually stabilization, and we stop. I mean, we recommend to stop myocare after 20 years old,
Okay.
or at least when it's 1 year stabilized. But it's not the first time that I'm hearing this. Do we have any other factors having an impact on myopia at this age, on the elongation of the eye? I don't know. I haven't seen any studies about children after 20 years old, honestly. What I know is that until 20 years old, and without 1 year of stabilization, this is what is the most common.
Right. Thank you. Thank you, Celine. Um, so, Mr. Mario Lekic, absolutely brilliant, precise geometrical optics masterclass in that 10 minutes.
Thank
I
you.
just had one question. What is the best frame shape that you would advise for myopia control lenses? And the second question I had for you was, do you still suggest dropping the the centration a little bit in terms of myopia control lens fitting as well, as you were talking about in single vision lenses?
Yes, first of all, the frame shape, the best frame shape actually is the one that the kid will accept. You know, they need to accept to wear the frames. You know, I heard some of the let's say example that during some of the countries they start, maybe this is another topic, but some of the countries they start to combine different solutions. So sometimes kids are not very comfortable to wear the spectacles in the school. So, you know, the ophthalmologist, they prescribe, you know, contact lenses during the day, and after the school, actually they start to wear spectacles, you know, just to refresh their eyes. So there are different solutions. So the frame for the kids is the one that they will accept. This is the first thing. When we talk about concentration of single vision lenses, especially finished single vision lenses, I highlighted that the most of the finished single vision lenses are designed based on pantoscopic angle of 0 degrees. So, and this is the reason why we need to lower down the center of the lens, you know, to align with the center of the eye rotation. When we talk about myopia solution, I would recommend to ask your supplier about centration of the different lens solution. When we talk about myocare care technologies or free focus technologies, we use the same way of lens optimization as we do for the high-end lenses, and it's required to lower down the center of the lens. Also, if you talk about single vision spherical lenses, we recommend to lower down the center of the lens. Is it?
Okay. Sounds great.
Yeah.
Because this was something that I really didn't know, because we were actually asked to mark the center mono PD on each of the lenses and then on the frames and then send it over. So this is probably something which is happening in the back office, which we are not aware of. So this is really brilliant information for us.
Yeah, to be honest, I'm struggling a lot of times, with the centration. And as I told you, we can have amazing refraction, we can have amazing lens solutions, but if we do not do correct centration, we didn't do anything. So, as Dr. Yazan told, that the results, centration can influence also the result of the myopia management. Yeah.
Absolutely. Thank you.
Yeah,
Thank you
thank
so
you.
much.
Thank you.
Ms. Heba, the information on counseling the patient, that was absolutely brilliant. Manage their expectations so you actually get a good result from the patient. And Dr. Naki, this was an absolute brilliant talk taking us through the evolution of the whole refractive surgery. There are a couple of questions. One is regarding the presbyon. What is the ideal age and how long does it actually last without issues based on your experience?
So Spayon is designed. Hiba, can I go to mute? So Presbyon is a technology that developed by ZEISS, it's proprietary. It's a technology where laser vision correction is actually used in a certain algorithm where the dominant eye is mainly focused at the distance, and it's the non-dominant eye has a little bit of more myopia, but however, the range of focus is not a monovision, and we all the optometrists are familiar with monovision, but this is actually with Presbyon, you get an extended depth of field and focus where there isn't this interruption of vision when the patient is looking with both eyes. And the typical age for Presbyon is 40 and above. It can be utilized for patients who are myopic. It can be utilized for patients who are hyperopic. And it's advocated sometimes for patients who are even, they're just to correct their near vision. Now, how long it will last? As promoted by Dan Reinstein, when counseling patients for Presbyon, you counsel them in a way that's saying, this is your vacation from your reading glasses. So is it forever? It's not forever. It buys you 5, 6, 7 years of reading glasses, sometimes 10 years. Now we know that accommodation amplitude reduces with age, and it's eventually, if that doesn't go away, the cataract will catch up. Now, is it a good solution? It's an excellent solution. What is the satisfaction rate? It's choosing the right patient. The satisfaction rate is high. The problem is when actually the patient, the incorrect patient is chosen for a certain technology. The problem is when we apply one technology for every single patient, and there where the mismatch between the expectation and the result happens. So once the correct patient is chosen, the patient satisfaction is very high. It is a technology that is available. It is a technology that is gaining a wider acceptance now. And I think this is something that is actually going to be practiced, and it is going to be implemented also in the competitor machines.
Thank you. Thank you so much. Ms. Ibrahim, there's a question on why do we need to do pre and post-op dry eye evaluations?
Say that is question again. I didn't hear it well.
Just a question regarding dry eye evaluation pre-op and post-op as well.
Dry eye.
Yeah. Sorry, my computer went to dead. I was in the background and my computer just ran out of battery. I'm going to join Hiba here in the session. So the assessment of dry eyes, Hiba mentioned the modalities of treatment. And we take dry eyes seriously here at the North American LASIK and Eye Surgery Center because we all know very well how laser vision correction induces dry eyes. And we you know, you as an optometrist and we as surgeons, we see dry eyes post laser vision correction. It's either intermittent or it can be actually long lasting. So if you start with someone who has a dry eye, and then you do a procedure that actually induces dry eyes, that you can have serious complications like flap melt, you can get reduced vision, you can have unsatisfied patients. We aggressively actually treat dry eyes pre-operatively. We diagnose dry eyes pre-operatively. And again, dry eyes is either due to lack of secretion, medication, or tear film instability. And Hiba mentioned in the tear film instability, like meibomian gland dysfunction, we readily, perform IPLs for patients who actually have meibomian gland dysfunction. We aggressively treat that before the procedures. We also treat them with cyclosporins if we see that they have, dry eyes before surgery. Cyclosporins have improved. There are 3 groups of immune modulators now. So we do treat them with immune modulators. We keep them on them for 1 or 2 months before surgery. And we also, we monitor the dry eyes after the procedures. So it's always linked, laser vision correction and dry eyes, especially when you have a flap. And dry eyes is really an enemy of the flap. And I have seen multiple cases of melting of the edges of the flap because of the dryness. So again, Smile it's a game shifter with us. We see this very, very little now with Smile technology. And it's even been shown, and I think a lot of research has been in India regarding the nerve regeneration in cases of Smile, and nerve regeneration in cases of cases of flap. And it's a very interesting to see how the nerve regenerates better in Smile, and it's interesting to see how the area gets denervated of the sensory nerves in LASIK and femto LASIK as well. So all of this, actually, these are the technologies that helps us with the refractive laser vision correction. So dry eyes is a big enemy of laser vision correction.
Thank you. Thank you so much. To Dr. Mohammed Al-Khatbi, we've had quite a few questions for you. One of which is there any scleral strengthening procedures done nowadays to basically reduce the axial elongation in high myopia?
Hello. So basically, there is not any procedure per se, but for schisis, for example, and and staphylomas. There is someone that came up recently with an indent to solve the problem of schisis. That is a posterior indent or macular indent, they call it. So slides in as a holster behind and elevates the fovea or the staphyloma area forward. But that does not strengthen the structure of the eye itself per se. It just changes the position of the staphyloma approximated to the retina where it's schitic. So for now, there is not much, no, unfortunately.
All right. So the other question that I had was, in high myopes with peripheral degeneration, say like a lattice degeneration, for example, is there a role for prophylactic laser retinopexy?
I'm a retina surgeon, so I see lots of problems from myopic lattice and pathological base of vitreous, even without lattice sometimes. So I'm pro laser normally, but used in moderation as well. So we shouldn't abuse laser as it can create inflammation and other issues in epiretinal membrane. And these retinas are very delicate. So for lattice only without any holes, micro holes or tears, and if we're using technology that's less manipulative, like PRK, for example, I don't usually, and if the patient is asymptomatic as well. So I don't usually do prophylactic, for there is no role of prophylactic here. So the patients I usually do prophylactic with, either they have history of detachment in the other eye, or they're going for more manipulative surgery and they have symptoms. So they have atrophic hole. I don't laser it actually unless they have floaters or flashes recent. So in the last 3 to 6 months, if they had the hole and snow is documented there before, then nothing. If they have the hole without detachment around it or fluid, and they're coming the first visit to see the surgeon, they refer them to me. I leave the choice to the patient in some cases, but the practice is symptomatic laser.
Okay.
Thank
And
you.
how often should we be suggesting a retinal evaluation? Does it really matter if they've undergone a retinal surgery, or does it matter if they've undergone a refractive surgery as well?
Yes, of course. So if they have gone, the problem with these patients is that they forget is that we solved one aspect of their myopia. Their myopia is still existent in a way or another. So we need to figure out the progression. Their refraction might change with time, or their axial length might increase. Rarely, of course, and the ages that they do after stabilization after their 20s, but still we need to follow them and verify their peripheral retina as well, or the possibility of them having any of these complications. I have seen 23-year-olds with neovascular membrane, myopic neovascular membrane with hemorrhage and everything. So no one is excluded. So better to have a follow-up, regular follow-up. Usually I ask patients to come sick yearly, even if they don't have symptoms, regardless of their status of refractive surgery, done or not done. They need to come follow up, especially if I pixie them or they have a very thin choroid, like you saw, or a staphyloma, or a beginning of schisis, things like that. So,
Right. Thank you. Thank you so much.
thank you very much.
Ben, is AI going to replace us altogether, or is it going to make things a little bit more efficient with us driving things forward in progress?
That's a great question. And I think that if you look around the world today, you see many jobs which are completely replaceable, but we still have humans in those roles. So you go to a bar and you have a drink because and there's a bartender there. The bartender doesn't need to be there, right? You can have you could go to a vending machine and you could press a button. You can have your coffee or your cola from the vending machine instead of going to a bar or a cafe and actually having a human serve you. And so humans value human interaction, and that doesn't go away with AI. And What we do find, and what we do see, of course, is that humans who use AI as an assistant or as a helping tool are able to perform more tasks than what they can do by themselves. They're also able to tackle a much wider range of problems than they can by themselves. And so what most likely, predicting the future is always difficult. What most likely will happen is that we will have access to more and more tools which enable us to be more and more efficient and more productive. And at the same time, we will have sets of users who want to keep sorts of customers who keep wanting to talk to humans and keep wanting to have human interaction, and maybe even some sets of customers who don't want to talk to humans anymore. But we should not underestimate the ability of these algorithms to replace very many or all tasks which humans can do. And if it's not possible to replace all tasks that humans can do right now, probably by the end of 2025, it will be the way things are developing. And so it's a great question, but I still think there's a place for us because humans value human interaction.
So true, so true. I mean, I can't imagine getting my coffee from a vending machine. I prefer to chat with the person who's serving the coffee to me, just checking on the day and the world and the whole thing at large, I think. So thank you. There are a couple of more questions in the chat box. I'm just going to quickly have a look at them and read them out. Right. Celine, I think there's a lot of questions for you in the chat box. One which says they want to know about the lens replacement criteria for the myocare lenses, like adaptation time or power change. Celine, you're on mute.
Thank you. It's too late for me. I should be in bed. So, just to reply to this question. So you have different warranties. The first one, because it's a treatment, what is important is to see myopia management as a treatment. So you prescribe something, you need to do the follow-up. Sometimes it's working, sometimes it's too slow, not enough, and so on. So of course, we are supporting you. We are supporting optometrists, ophthalmologists, and dispenser. So if there is any power change up to 9 months after the date of purchase, we change the lens for free. Then you have adaptation warranty. So for any reason, if there is an inadaptation, we give the best of our lens instead of myocare. So the best lens designed for children as a single vision. Okay, so this is up to 1 month. Then in the upcoming year, when you look at the design of myocare, you have a central clear zone, and then you have a functional zone with rings, which are the care elements. If you have a big scratch, it's not going to be good, and so the treatment is not going to be efficient. So we are supporting, and we know how our children can be, right? So for the first replacement, either scratches or breakable, we do a 70% discount on the lens. And if it's happening the second time during the year, we do a 50% discount, okay? So this is really how ZEISS, you know that ZEISS is a foundation, right? This is also why we have this stock lens, which is really affordable, the same price as a normal single vision. We are doing many actions. I mean, having a lens and as a foundation, we are really supporting as much as we can doctors, ophthalmologists, optometrists to give best eye care. So this is really the type of warranties we have.
Thank you. Kani, are there any more questions that we need to take from the chat?
Thank you. Handled most of the questions. There is one in the chat box. They want to know, is there any short-term courses or fellowship course where they can do this myopia specialization? Basically to become a myopia management courses like that. Anyone of this?
Yeah, if I can say so, we have this online certification. Okay, it's just the first unit, which is having 5 courses. I am having a dedicated myopia management training that we have been working with Dr. Yazan. I also have another training. I mean, if you want to be trained, we can train, but you need to reach out to me. So please send me an email, celine.combrose@zeiss.com, and me or someone from the team will come to you. You will have a ZEISS certification. And then I think it's really country regulatory dependent. If there is any dedicated exams and that you can have. I don't know about this. It's really country dependent, like PhD, masters, or what. I'm not sure about that. I know that I can train you about myopia management and especially about optical lens, all the different techniques and history with optical lens, not about auto-K, but we can give you the awareness of what is been doing. I just would like to reply to one question, which is why do we have stock lens with 1.59 and why not 1.6? This is a very good question. Yes, you are right. 1.56 index in terms of vision clarity and aberrations is way better. In terms of safety and breakable, 1.59 is today the hardest lens. Okay, it's like that. We have to find a compromise. What do we want? Do we want the safest lens, which is unbreakable, or do we want the best clarity? I understand all eye care professionals who prefer, for now, to prescribe 1.59. And this is the reason why we had to make the choice and we decided to take 1.59 as a stock lens. On top of that, having 1.59 as a stock lens is going to make it cheaper, so more affordable and so more accessible. And this is, once again, as a foundation, what we are looking for. We are looking for accessible solution to slow down myopia. And when you look at all solutions available, this is definitely the easiest one, non-invasive and affordable compared to ortho-K, compared to atropine. Yeah, so this is why we made this choice. Just another answer, we have 2 designs, myocare hard design, myocare soft design, same concept, just the value of the defocus is higher for the hard design and lower for the soft design. The size of the central zone is smaller for the hard design, wider for the soft design. The idea is to give you the most options to find one which is suitable for your patient. I would suggest to try and to optimize it with the hard design as a first intention, so that if you have any problem, you can try the soft design. But it's really dependent on your patient. If it's a 16 years old children who already tried progressive lens when he was 10, he hated glasses, so you just have one shot, please go on the soft design. In terms of studies results, both are working, both are efficient. So hard design is not better than soft design. The only thing is that it might be stronger and faster on small children because we know that the myopia progression is more aggressive. So it's better to have a hard design to make it stop faster. But in terms of result, in all our studies, it's the same. And I think I replied to all questions.
Good.
Thank
Thank you
you.
so much, Haramia, for moderating the session. And thank you all speakers for the very informative and wonderful session. And Celine, we are looking forward for the next session also. I will pass on to Swarna Kamal for the closing remarks. Thank you all again.
Ladies and gentlemen, dear colleague and guest, as we come to the close of today's insightful webinar on refractive error management part 2, I would like to take a moment to thank all of you for your time, participation and enthusiasm. First, a heartfelt thank you to our distinguished speakers, whose expertise and contribution have truly enriched today's discussion. Your knowledge and insights have empowered us all to better understand the complexities of refractive error management. A special thanks to our sponsor ZEISS Vision Care Middle East for their generous support and commitment to advancing eye care education in this region. Your collaboration has been instrumental in making this event a grand success. To all our attendees, thank you for being an active part of this session. Your dedication to the professional development is what drives forums like this to thrive. We are delighted to share that this webinar has been accredited with 1.5 CME hours by Dubai Health Authority, and your CME certificates will be delivered within 21 working days in your registered email ID. Finally, I am excited to announce our next big event, the Myopia Conclave Dubai, a hybrid event designed to bring together industry leaders, researchers, and practitioners to address the challenges and advancement in myopia management. And save the date, it is 23rd March 2025 to celebrate World Optometry Day. Stay tuned for updates by following our website, that is www.uof.world. Once again, thank you for making today's event a grand success. We look forward to seeing you at our upcoming events. Until then, stay inspired and keep contributing to the achievement of vision care. By the way, third part also coming soon. Have a wonderful evening. Good night, everyone.
Thank you, everyone. Thank you, UOF.
Thanks a lot. Bye, everybody.
Bye, everyone.
Bye.
Bye-bye.
Thank you.
Thank
Bye-bye.
you. And bye-bye. Thanks a lot.
Bye.
Thank you.